Okay, part two of this online YouTube PowerPoint deal that I'm doing instead of class today. So you're welcome, and I'm sorry. I understand that it's a little bit a little bit more work for some of you than just sitting in class, listening or not listening. But hopefully this is an effective way to get some of this information out. This presentation should be shorter. We're going to go over injury evaluation. For those of you that have had my rehab class, this should all be a review. For those of you that haven't, we're going to use some of this information as we get into specific body parts, evaluating injuries. This is really useful information to know. All right. So we'll talk about a couple different types of evaluations of injuries. Basically, it is obviously an essential skill for any of us in the class this semester. I mean, you need to know how to evaluate your patients that you're going to see, whether you're a personal trainer, an occupational therapist, a physical therapist, a speech pathologist, a high school coach even. These are really good tools to give you basically a diagnostic method to getting to the core of what's going on. All right. So the four we're going to talk about today: the pre-participation physical, that would be prior to the start of the season. The on-the-field assessment. These two are most likely evaluations that an athletic trainer is going to primarily be involved with. The off-the-field evaluation performed in the clinic, the training room, the physical therapy clinic, the hospital, wherever that is. It doesn't really matter, but all of us will be involved in these off-the-field evaluations, all right? And then a progress evaluation would just be mainly we think of for like a physical therapist as a repeat visit, all right? How much progress are they making? How do we know what kind of progress they're making? A diagnosis. Basically, this forms what we're going to do for this patient throughout the duration of their rehab or rehabilitation. Physicians are the ones to make medical diagnosis. So therapists, athletic trainers, we do not make diagnosis. We can prognose. The term prognosis is just our opinion of what we think is wrong. The physician will then make the medical diagnosis on top of that. All right. So going through evaluation information, basic knowledge requirements, we all have to have some general knowledge. Well, we're really, to be a good sports medicine professional, you need to have a more in-depth knowledge of all this, but it's absolutely imperative that you do have a general knowledge of anatomy and biomechanics, as well as a lot of us with biomechanics that are associated with a particular sport as well. But all of us need to know surface anatomy. What are we looking at when we've talked about the term palpation. What part of the bone is this? What bone does this articulate with? What muscle attaches to this bone through what tendon? So really important that we know surface anatomy, and that we really need to know body planes and anatomical directions. A lot of that we cover in rehab, but most of you, hopefully you're getting that in kinesiology, exercise prescription, personal training, those courses as well. Very, very quickly, I just wanted to show you that there are 4 abdominopelvic quadrants, all right? And these are referenced by where they are on your body, all right? Right upper, right lower, left upper, left lower. And there are specific organs and tissues that are in each of these quadrants. We're not going to cover those specifically. You can research those more on your own if you want. Just wanted to cover a few assessment terms and some of the terminology we're using in evaluating. Mechanism. Mechanism means how did the injury occur. A sign is something that I can see. A sign would be swelling. A sign would be bleeding. A sign would be deformity. A symptom is something that the patient or the client is going to tell me about. So that's something, not necessarily something I can see. That would be their description of how the injury feels. So numbness, tingling, burning sensation, those sort of things. Those are symptoms. All right. Prognosis we talked about. This is a key term for the rest of the semester. All right. This is definitely a question I'm going to ask you on the quiz on Thursday. What is a differential diagnosis? Really what a differential diagnosis is referring to is if I suspect someone has torn their ACL in their knee, what other injuries could that potentially be? So I can do all my testing and say, like, I'm pretty sure that it's a torn anterior cruciate ligament. But it also could potentially be what other injuries. That's what we're talking about when we talk about the differential diagnosis. All right, and then you really need to know these terms, these reference points. All right, medial, lateral, superior, inferior, anterior, posterior, proximal, distal. All of those terms you should already know, so I'm not even going to cover those. If you do not know a lot of those terms, we need to talk and have you review some of those. All right. The injury evaluation is divided into 4 components. Really important. Again, this is the type of information we're going to use the rest of the semester. HOPS is our acronym. It stands for History, Observation, Palpation, and Special Test. And we'll go through each of these one at a time. All right, our history is where we're obtaining subjective information relative to how the injury occurred, the extent of the injury, the mechanism of injury is MOI. So this is what the patient or the client is telling us about what they experienced. All right, this is really, really crucial information because most of the time we aren't at the injury site. We didn't see how it occurred, especially if you're not an athletic trainer. You know, for me, I may be on site watching practice and I see something happen. That gives me an upper hand, but many times physical therapists are seeing clients that come into the clinic after they've already been injured, so you didn't see the injury. Really, really important here to take a thorough history and ask open-ended questions that the client can answer that will give you an idea, really good idea of what the injury is. So what's the problem? How and when did it occur? Did you hear or feel something? Which direction did the joint move? Can you characterize the pain? What sort of pain is it? Is it a dull, achy pain? Is it a sharp shooting pain? Those sort of questions. All right, so after history, we move to our observations. This is what we can see. Pretty simple. Are there movements abnormal? What's the body position? Are there any asymmetries? How does the athlete move? Abnormal sounds. You know, is there anything that we see that's out of the ordinary? And many times, we'll talk about the rest of the semester, we need to compare bilaterally. So if I'm looking at a knee that someone says they've had an injury to, I want to compare it to the good knee to see what exactly might have happened. All right, moving on. History, observation. Next one is palpation. So palpation is essentially you are putting your hands on the patient or the client and trying to feel for any deformities, any crepitus, any abnormalities. And I want to just palpate these certain areas. I want to palpate bones. I want to palpate muscles, tendons. And I'll make sure that they feel as they're supposed to, okay? And I talked about this a little bit when we were going over our ankle taping, but it's imperative that you understand what normal tissue feels like so that when you feel tissue that is abnormal, you understand what that feels like, all right? And we'll practice a lot of that the rest of the semester. Finally, history, observation, palpation, moving on to special tests. Special tests are used to detect specific injuries, specific pathologies. We're basically comparing different types of tissue and their integrity. What that means is, again, going back to my ACL patient, if I think my ACL patient has torn an ACL, I want to compare how tight is that knee compared to their other knee, all right? And I always want to compare bilaterally. Range of motion assessments, we're going to start with an active range of motion assessment. So what I'm going to ask the patient to do if they've hurt their knee is, can you actively extend your knee? Can you actively flex your knee? If they can't, then I want to go to a passive range of motion. All right. If it's painful actively, that would indicate that there's muscular injury. If it's painful passively, we're then taking the muscle contraction out of it. So that would negate any muscular injury, or should negate most muscle injuries. Goniometric measures. In rehab, we talk about measuring range of motion of joints using goniometers, and you'll do some of that if you haven't already. This is just a way that, as we talked about those progress evaluations, this is a way that I can look and see, all right, this person has about 75 to 80 degrees of knee flexion. All right, when they come in again, maybe their knee flexion is at 90. When they come in again, maybe their knee flexion is at 115. That is a way that concrete, objective way that I can assess how much range of motion they have. All right, some neurologic and circulation assessments. Obviously, we want to assess brain function, sensory and motor function. The way we assess sensory and motor function from a clinical standpoint is using dermatomes and myotomes. So dermatome is an area of the skin innervated by a single nerve. Myotome is a muscle or group of muscles that are innervated by a specific motor nerve. I want to show you, basically this is a dermatome chart here. So what we're looking at is what specific areas of the skin are innervated by what specific nerves, all right? Cervical, thoracic, lumbar, sacral, That's what we're looking for here. And we'll go a little more in depth on this because I do want you to be able to do assessments in dermatomes and myotomes in an evaluation. Really important. Let me cover this real quick. If we find that there's a deficiency in one of these motor nerves, then that will indicate that perhaps it's a neurological injury rather than maybe a more severe musculoskeletal injury. All right, finally, really what we're talking about the rest of the semester we'll focus a lot on is this joint stability testing, motor testing, and functional performance. How do we test the ability of the athlete to move and function as they need to so that they can participate in sports? And that's really what we're focusing on. Very, very quickly, I just wanted to cover documenting injury. So a lot of you want to go into PT/OT setting. This is really important for you. You need to make sure that your records are complete and accurate. You know, this is basically to cover your own behind. All right, that's essentially what it is. You've got to make sure that you spend time on this. In fact, many of you that have done shadowing have seen your physical therapist spend a lot of time doing record keeping and documenting injury evaluation information. It's also really important that we have this information so that down the road we know how they've progressed, as I just said. All right, how do we keep this information? We keep these in what we call a SOAP note. That is also an acronym. And we'll go through this. This is a systematic way to keep notes. Really simple. So I just wanted to show you this. Subjective statements that are made by patients. So this is where you're taking all that subjective information that they give you in. Objective, what do I find? All right, when I evaluate them, what do I find? When I look at them, you know, when I'm observing, what am I seeing? Assessments is now this is where I'm starting to do my special tests. This is where I'm starting to do my different assessments on them. That's going to give me more information than I already have. All right, and then the plan would be the final thing. So now I take all this information I've gotten from the subjective, objective portions and the assessment, and I put it into a plan on what am I doing now. You know, where are we going from here? Is this first aid treatment? Do I need to refer them? What sort of goals do I have? Is this a range of motion goals? And you know, where do we go from here? Additional diagnostic tests I'm not going to cover, but you've heard them before. All right, we're talking about X-rays, arthroscopes, CT scans, bone scans, MRIs, ultrasounds, EKGs, blood tests, and urinalysis. These tests important. These are tests that we would refer out. If we didn't get enough information from our assessment, we need to refer out and get more diagnostic tests to make sure we know exactly what's going on. All right, this picture here, probably either a knee dislocation here or fracture or fracture. So there may be a lower leg fracture here or a dislocated knee, either way. All right, that was very quick again, but you will have a quiz over this information, and then Thursday we're going to cover the healing process, but we're going to start with a quiz over Chapter 12 and Chapter 13. So enjoy your quote-unquote day off. I'll see you guys Thursday. Let me know if you have any questions, but this is information that will be on the test, and I think it'll be a fairly effective way to get it on there. But hopefully it wasn't too fast. The good thing about it is you can watch this over, and I'm sure many of you will watch this over and over and over. So anyways, again, let me know if you have any questions. See you guys Thursday.